Good morning and all. My study title is a retrospective review of cataract surgery outcomes in patients with non-ophthalmus. Non-ophthalmus is a rare genetic disease with a small eye secondary to compromised growth. It is characterized by short axial length, high lens by eye volume ratio with narrow angle, high hyperopia and scleral thickening. A sudden decompression of the globe following any kind of surgery may result in rapidly progressing choroidal effusion and suprachoroidal hemorrhage. So some authors will consider to perform forced sclerostomy before opening the eye. Our aim of the study, the cataract surgery outcomes in patients with non-ophthalmus in tertiary eye care hospital respectively. Materials and method, we included patient age more than 20 years with axial length less than 19.6 millimeter, and we excluded age less than 20 years and with axial length more than 19.6 millimeter. It is a retrospective study. We included 25 patients, that is 46 eyes with non-ophthalmus, and study period is 8.5 years. We measured visual acuity, intraocular pressure, pre-peripheral iodectomy and post-peripheral iodectomy, cataract surgery data, intro-op, post-op complications, and post-op visual acuity. The patients were taken up for surgery only after controlling the intraocular pressure by doing prophylactic ACT peripheral iodectomy and by giving adequate intraocular pressure lowering agents. And the results were, out of 25 patients, the mean age was 54.44 years, and the gender distribution, females are 19 were females and 6 were males. Out of 25 patients, 3 patients are non-ophthalmus associated retinitis pigmentosa and consecutive optic atrophy, and 21 patients were bilateral and 4 were unilateral, and the mean axial length were 18.36 millimeter. IOL power ranged from 30 diopters to 44.5 diopters with a mean of 40.5 diopters. And out of 25 patients, 8 patients underwent peripheral iodectomy and 7 patients have not underwent peripheral iodectomy. Most of the patients were within 10 to 20 millimeter of mercury. Out of 25 patients, 18 patients underwent cataract surgery. In this, both eyes patients were 9 patients and one eye patients were 9 patients. All the patients pre-op intraocular pressure was normal, and the 7 patients out of 18 patients, 1 patient intraocular pressure was 60 millimeter of mercury pre-operatively. So IOP was controlled with topical and oral anti-glaucoma medications and IV mantle 1 hour before surgery, and the surgery was uneventful. Post-op visual acuity, in 11 patients there was no drop in visual acuity, and 16 eyes there was improvement in the pre-op visual acuity. Coming to discussion, non-ophthalmus is a rare clinical spectrum of disorders with phenotypically small but morphologically small eyes. Cataract surgery in non-ophthalmic eyes is often challenging with poor visual outcome and potential complications such as uveal effusion, retinal detachment, and corneal decompression. These eyes are more prone to develop uveal effusion either from thickening of sclera and reduced scleral permeability to protein, or from dense collagen around the vertex wings resulting compression of venous drainage channels. In the present study, we had done phacoemulsification with IOL implantation in 18 patients. The surgery was done after controlling the intraocular pressure adequately, and we had done cataract surgery without doing sclerostomy. None of the patients had any uveal effusion intraoperative or postoperative. Similar to the study done by Fosher et al., all the sclerostomy was not performed. Prior to phacoemulsification, none of the patients landed in uveal effusion. In a study done by Sharmila Rajendra Babu et al., they had done cataract surgery with sclerostomy and without sclerostomy, out of which 3.33% patient had uveal effusion as a complication in cases with sclerotomy, and 12.76 patient had uveal effusion in cases without sclerostomy. In another study done by Sharmila Rajendra Babu et al., 12.9% patient who underwent cataract surgery without sclerostomy had uveal effusion as a complication, but none of the patients in sclerostomy group had uveal effusion. So I conclude none of the patients had any intraoperative postoperative uveal effusion. By controlling intraocular pressure prior to the surgery by either giving oral glycerol or IV mannitol and by doing ACT peripheral iodectomy when required, complications like choroidal effusion, suprachoroidal hemorrhage can be avoided without doing sclerostomy prior to the opening the eye. These are my references.
In some of the patients in both the groups, you had not done peripheral iridotomy. Still, they did not present with the uveal effusion. So how do you explain that? What measures did you take in those patients? You said measures, if you want to avoid sclerotomy, then you have to take those measures like peripheral iridotomy or conservative measures like mannitol, etc. But in some of the, I think almost half of the patients, you did not do peripheral iridotomy.
For that patient, before going surgery, we have given oral glycerol, sir.
Oral
to
glycerol
decrease the
was given in all the patients with PI or without PI,
Yes,
right?
sir. Yes, sir.
So, which was more effective then? That means PI or conservative measures or combination of both? How do you cannot have conclusion like that then?
PI was effective in the eyes more prone to angle closure. I mean, in none of the almost all eyes are not prone to angle closure. In some eyes, it is open angles also. No, sir.
Yeah, I agree with that. But there was none of the eyes that required any glaucoma procedure?
Our sample size is very less, ma'am. So
Okay, thank you.